some interpretation. We need to score these on a 1 to 5 scale. There is a work in progress, something that's been put out called PIRADS, which describes a 5-point independent scoring scheme for T2, DC, MRI, and diffusion-weighted imaging. I discussed this in an earlier presentation. The approach that I think most people, including myself, are taking that do a lot of these is a hierarchical interpretation approach. First looking at the T2 and diffusion-weighted images, and then looking at the DCE last. Look at the peripheral zone first, the transition zone second. And so looking at the peripheral zone and then all the anterior structures in a separate style of interpretation, and always ask for the prior biopsy results in PSA to help guide your interpretation. One of the things that I will do in those cases where our referrers don't have access to actual images is I will use a legend like this to describe the locations. This is in the European Radiology Review describing PIRADS in terms of this sort of grid. This is what my report looks like in those cases where we don't have screen captures or images we can put in the report. And so this is important that you've got to convey this localization information. So here's a case, 1.5 Tesla MR, no endorectal coil. And this is the kind of quality you can expect in a fatter patient, someone where the coil is fairly far from the prostate. You can see that the T2 weighted imaging is relatively noisy on the far left. This is a B800 diffusion weighted raw image. And then this on the far right is an ADC map, window leveled at 1600 by 1600 in this case. So that 14 to 1600 range. Where's the tumor? And I think I interpreted this as a 28 by 12 by 20 millimeter anterior tumor involving the anterior fibromuscular stroma. So over here, these two nodules. If I look here, it's harder to assess the morphology because of the poor SNR here in this particular patient. But if you look and you correlate the restricted diffusion, this appearance and this appearance across all three, it's clear that this is a definitive cancer. And this is where I think you need more experience. As you move to the lower field strengths and move away from the endorectal coil, you will benefit from having had that experience with the endorectal coil or at 3T, but certainly more of a challenge at 1.5T, certainly on the older systems. What about staging? The general approach to staging is to undercall, so obvious right-sided peripheral zone cancer here, obvious extension here into the seminal vesicles on both sides, and so this is bilateral extraprostatic extension, T3B tumor in this case. Another case of fairly obvious extraprostatic extension, we can see clear gross tumor extension into the left seminal vesicle, and in fact some right extraprostatic extension here, just inferior to the seminal vesicle. And this is where imaging in all three planes with T2 weighted imaging is important. This can be done using a 3D sequence. I still prefer to do this at 2D. I find the images to be sharper in all three planes and not that huge a time savings, 2D versus 3D, to get this image quality, at least on our systems right now. So bilateral extraprostatic extension, high-grade disease in this particular case on pathology. Here's a sort of a very advanced case. Again, these are obvious cases of extraprostatic disease with an endorectal coil. These were done at 3 Tesla, and you can see this clear-cut tumor on the patient's left side, high-grade, high-risk Gleason 9 disease. Here we have extraprostatic extension that extends out laterally on the right side. This patient was DRE negative, Gleason 8. Surgeon elected to still operate and do what is very common, which is to use the MR to guide nerve-sparing surgery. In this case, nerve-sparing surgery was done on the left side, and the neurovascular bundle was sacrificed on the